Thanks, and thanks for the GIS committee for putting a great conference with great talks. So I think conduction abnormality is going to be with us for a really long time, and I still struggle with it until this day. Nothing to disclose about this talk. So conduction disturbance after TAVR is still the Achilles heel for our work. We still deal with the high degree of a block, left bundle branch block. Imagine yourself practicing literally in 2008, where I remember we had to keep patients for up to 10 days because we do not know how to handle left bundle branch block or a complete block, heart block at this time. Our job as a TAVR operator, pre-TAVR, is to look closely at what is the risk of this patient developing a permanent pacemaker. How can we reduce the incidence of a permanent pacemaker through meticulous screening and maybe improve procedural technique, and subsequently a lifelong journey for specifically low-risk patient who might end up, unfortunately, with a pacemaker. And what do we deal with the post-TAVR length of stay that unfortunately related to the conduction abnormality? I'm going to kick it with 3 cases, and I'm going to visit those cases at the end. The first case is a 77-year-old female, symptomatic low-graded AS. She does have AFib, hypertension, limited mobility, and high BMI. ACG, as I could show you here, AFib with neurocurus complex. The size or the perimeter of the valve was 68. No much difference between the LVR slow tract and the annulus. The size of the valve we picked is a 26 millimeter valve with an oversized ratio of 17%, high deployment, got happy, and an intentional deep aortogram to see the level of the deployment. Patient developed left bundle branch block. The question that comes to mind, how long are we going to keep her in hospital? Any further outpatient therapy? And I'm not going to poll the panel, but I will ask him towards the end. The second case is a similar case, 72, morbidly obese, AFib, chronic kidney disease, stage 3. She does have an essential frailty tool of 2, limited mobility, severe AS. The annulus, the perimeter was 70. She had a low-lying left main, good access. She does have no major calcification in the LVR slow tract, and just major calcification involving the STJ. Her ECG pre-procedure had right bundle branch block with atrial fibrillation. And the last case is just as recent as last week, 69-year-old male who declined open heart surgery, true low-risk patient who, despite convincing, declined open heart surgery. ECG before LVH, no conduction abnormality. Thinking about the future of this guy needing another valve, we picked a balloon expandable valve. If you look at the oversize ratio, if we go by the bigger size, it's a significant oversize, intentionally undersized and overfilled the valve, high deployment, hoping that we're going to end up with no conduction abnormality. And I'm just going to allow the second film to work. And this is the aortogram post. And next day in the CCU developed new left bundle branch block with normal PR interval. So the conduction system as we know it, or as we structural cardiologists know it now, it all relies on our knowledge of the membranous septum and where that exit point for the HIS in relation to that membranous septum, as I'm going to show you subsequently. That length is very important. Older data showed that the pacemaker rate is clearly higher in self-expandable valve compared to balloon expandable valve. 6% for the first generation Edwards versus 25 to 28% for the core valve. Over the time we improved. We went down slightly with the XT, but subsequently with operator experience using the Sapien 3 for the first time and applied the same knowledge of the XT, we ended up with a higher pacemaker rate, readjusted the technique, and the pacemaker came down to 10%. And as you see in the real-world registry, between 7 initially in the XT, up to 12% in the Source 3, with clear improvement in other parameters related to TAVR. With the Evolute, similar scenario, we are seeing as recent as 11.7% for the cusp overlap technique, and recently in the scope 1 and scope 2 trying to find out whether a specific valve is better than the other. For the accurate versus the Sapien, we did not see a major difference in the pacemaker or a meaningful difference in the pacemaker. Accurate versus Evolute, definitely
if you look at only the pacemaker, there is an advantage with a shorter valve, the accurate new 11% versus 18% for the Evolute. Now, with more operator improvement and refining the technique, this just recently presented in PCR, looking at specifically using the cusp overlap technique and swinging between two views, including the LIO view. The pacemaker came down definitely to a lower number. The implant depth was maintained around 3.1 to 3.4, which is really amazing for the operators. The permanent pacemaker rate came to single digit. Now you're talking about 9.8%, which is excellent for a self-expanding valve. How are we doing in real registries? This is one of the largest registries, the TVT, and you can see that the pacemaker rate has been steady despite a tremendous improvement in the mortality, 7.2% versus 2.5% recently. Is pacemaker and conduction abnormality harmful? I used to say they are, but recent data made me also debated that. This is, again, from a larger registry comparing within Scandinavian, I think published by Jorgensen, 800 patients, and basically they looked at their outcome if you develop bundle branch block or a pacemaker, and clearly if you have no conduction abnormality, you fared better compared to patients who develop bundle branch block or develop a pacemaker in relation to heart failure admission and mortality. Within the TVT registry, similar trend. If you have a pacemaker, probably you will end up with a higher mortality and more heart failure admission over time. But then the Swedish or the Swedeheart published a good registry, observational registry, that specifically looked at almost 1,200 patients. And they classified them according to whether or not they have the pacemaker. And actually, the pacemaker rate within that study was 14%. And when you look at the mortality, there was no much difference between the two groups. This is also a longer-term data, quiet outside the box compared to previous data. And so that's why also the Quebec group published a similar analysis. So again, if you are a debater about the role of the pacemaker, maybe, but most of the randomized trial and large registries did show that having a pacemaker or conduction abnormality is a bad thing. And if we want to compare ourselves to surgery, definitely we are far higher risk. Now, outcome for pacemaker, for a low-risk patient, this is very meaningful. This is an exposure over a year to multiple complications related to the pacemaker, device infection, lead failure, and possibly the heart failure. What do we do as operator? We have limited things before the procedure. LVR flow tract calcification, ECG and age, atrial fibrillation, and septal length. These are factors that we cannot change, but it's very important for us in order to consent the patient. Recently, our ability to predict has been improved dramatically. This is a score from Emory, where basically they looked at more than 200 patients, the applied score. I have not seen the score validated subsequently, but within their validation cohort, if you have 4 out of those points, you're 40 to 50% chance you are going to need a pacemaker. This includes a syncope, right bundle branch block, or if you have a QRS complex more than or equal to 140 millisecond, or if you oversize with any platform more than 16%. The new thing, it's not new, it's such, we know about it from before, but now we are seeing more application. The length of the membranous symptoms. It's a very great tool. We did not analyze it before, but now we are seeing more TAVR report with this. And basically what it tells us, the His comes and penetrates between the ventricular, between the LVR flow tract, till it penetrates the muscular part of the septum. Where it exits in relation to the membranous septum is very important. The further away that exit point, the less likely you're going to have a pacemaker. So if you have a membranous septum less than 6.8, 37% chance you would require a pacemaker, versus if you have a membranous septum more than 10, that's again a very high negative predictor for needing a pacemaker. More importantly, within that publication, if you are out of the lucky people who have a pacemaker, who have a HIS that actually exit in the right ventricular side, you are unlikely to develop a pacemaker or conduction abnormality. Within the same publication, 2 patients, same exact implant depth, but one had a membranous septum that is really short, of 3 millimeter, and you see the difference. Both of them, one had a conduction abnormality, the other has not because of their membranous septum. So how about the procedural planning? And that's where I think the TAVR operators have to up their game. Do we really have we seen or have we selection in terms of device choice to reduce pacemaker? Absolutely, we are seeing a difference between self-expandable and balloon expandable, but even within the self-expandable, the operator had clearly improved to bring the pacemaker rate to a single digit. Pre-dilatation has been also a reason for needing a pacemaker. Oversize ratio is a factor that the operator can control the depth of the implant and post-dilatation. For both platform or most platform, if you have a depth implant that is deep, definitely you're going to end up with a pacemaker or a bundle. For example, for a self-expanding valve in here, the evolute, if the depth of the implant is more than 6 millimeter, you're likely to develop a bundle, versus if you have a depth of implant less than 6 millimeter. The same analysis was done with the XT system, and if you have a depth less than 3 millimeter, probably you're not going to end up with a pacemaker. This is a very nice, within our early Sapien 3 experience, we used to deploy XT 50-50, then Sapien 3 come, taller valve, we deployed it the same way. We find out that our pacemaker rate almost doubled, 25%. Then we started to deploy the same ratio, 80-20 or 90-10 in some cases, and that's when the pacemaker rate nicely came down. So the predictor for post-procedure, which is a difficult part for us, and that's what we deal with, and increase the length of stay, new left bundle branch block, right bundle branch block, or even if you have somebody with a bundle branch block and you have a QRS prolongation or PR interval prolongation more than 20 milliseconds for the QRS complex, or if you have a slow atrial fibrillation. Most of us have dealt with those patients where you truly are struggling, when can I send patient home? Very easy. This came from, again, very nice publication from the same group about how they triage patient post-TAVR. If you have a patient with a normal ECG, pre and post-TAVR, this patient should have the pacemaker out and should go to a telemetry unit and should go home within 1 day. If you have a patient who have a QRS complex prolongation or a PR interval prolongation, you could leave the pacemaker and then see what happened with the ECG subsequently. More importantly, we are having more tools now. Rabid atrial pacing has been utilized nicely in the cath lab. If you have the same pacemaker, put it in the right atrium and start to pace. If you see a winky back, that came as one of the strongest predictor of needing a pacemaker. Almost 11 for the odds ratio, needing a pacemaker. So if you pull the pacemaker, start pacing, and you see a winky back phenomena, a very strong predictor that this guy will need a pacemaker. The potential pathway that personally in my center that I usually deal with, normal ECG, no more, we do not leave the pacemaker in place. Any QRS prolongation, that's when usually I leave the pacemaker in place and follow. Patient who does have pre-existing bundle branch block, specifically right bundle branch block, I intentionally asked to put for me a line in the neck in order to leave the pacemaker longer. So back to my cases. The first case, left bundle branch block, what we did is we did the HIS ventricle interval, and there are a couple of publications I did not include here to tell you that if you have a good EP guy who really like you and happy to spend 15 minutes to do an EP study for you, his ventricle less than 70 milliseconds has been a very strong predictor, not needing a pacemaker. My lady has 50 milliseconds, so basically I left her without a pacemaker. This lady with a right bundle branch block, we elected, because of the left main, to use a specific platform that we believe that has a lower pacemaker rate, and this lady, in follow-up, she had the same conduction abnormality. It did not change. The last guy, who's really a young guy, so we chose a balloon expandable valve, thinking about the future for a TAVI in TAVI. Unfortunately, he developed left bundle branch block, no PVL, 8 millimeter gradient. The oversize ratio was in fact -5. But if we add the 1cc, it was really not oversized. We just observe him, and the plan is to send him with an implantable loop recorder. If you want to bring my summary slide, that's fine. Otherwise, I could tell you in my summary that as TAVI operator, we really need to invest in the pre-procedural predictors that we know that can help. But within the procedure, the depth of the implants and analysis of the membranous septum, avoiding pre-dilatation, is of paramount importance to reduce our pacemaker rate. Thank you.